So imagine you are, standing at the bedside of a patient in the intensive care unit,
Okay.
and deep inside this patient's body, there is this terrifying physiological crisis unfolding. Like millions of microscopic blood clots are just forming inside their tiniest blood vessels.
Right? Just everywhere.
Yeah, everywhere. And these microclots are systematically blocking off the oxygen supply to the kidneys, the lungs, the liver, causing those vital organs to just slowly suffocate and fail.
Which is a complete nightmare on its own.
Exactly. But then at the exact same moment, a nurse steps up to the bed and pricks the patient's finger for, a routine blood draw. And instead of clotting over in a few seconds like it normally would, that tiny needle stick just starts bleeding uncontrollably. I mean, the blood just keeps pooling.
Yeah.
So the patient is simultaneously clotting to death from the inside and bleeding to death from the outside.
I mean, honestly, it sounds like a complete biological impossibility.
Right.
Because if you look at standard physiological models, you're either, a clotter or a bleeder. The whole coagulation cascade is fundamentally designed to prevent one extreme or the other.
The balancing act.
Exactly. You really shouldn't be able to experience both extremes at the exact same time, in the exact same circulatory system.
Well, today our mission for this deep dive is to figure out exactly how the human body manages to break all its own rules to create that exact impossibility.
It is such a wild topic.
It really is. We are looking at disseminated intravascular coagulation, or DIC, and we've pulled together this really fascinating stack of sources for you today.
Yeah, spanning everything from medical history to cellular pathophysiology.
And even some really intense critical care debates, because we want to help you unpack this condition, which the literature often calls a consumption coagulopathy.
Right. And this specific phenomenon, it forces a complete recalibration of how we think about human disease. Well, it demands that we look past the really obvious outward symptoms, like, a bleeding IV site, and drill down into the hidden chaotic mechanics of the vascular system.
Okay, let's unpack this, because I feel like we can't really grasp the magnitude of the paradox until we establish the baseline.
Sure.
So think of your body's normal clotting system as this highly efficient, highly localized supply chain. Like normally, if a pipe bursts, say you get a cut on your arm, your body sends all its raw materials to patch that one specific hole.
Right, things like platelets and a protein called fibrinogen.
Exactly, it's targeted. But DIC is like this massive systemic glitch in the master computer.
Yeah.
It essentially orders the factory to build millions of tiny, totally useless roadblocks on every single highway in your body, all at the exact same time.
And what's fascinating here is the underlying biological trigger for that glitch. Because the entire cascade basically comes down to a protein called tissue factor.
Tissue factor.
Yeah. So under normal circumstances, tissue factor is hidden away completely outside the blood vessels.
Like tucked away in the surrounding tissue.
Exactly. So when you get a cut, the blood escapes the vessel, encounters that hidden tissue factor, and boom, the alarm bell rings.
With a proximity sensor.
Basically, yeah.
Yeah.
It tells the blood, hey, we have a leak right here, start building a clot. But in DIC, that tissue factor is suddenly exposed inside the blood vessels.
Systematically,
all over the body. So the alarm is just ringing everywhere.
Oh, wow.
So your body naturally initiates massive thrombin generation in every blood vessel simultaneously. And this is the actual mechanism driving the consumption part of consumption coagulopathy.
Because the body only has so many supplies.
Right. You only possess a finite reserve of platelets and clotting factors at any given second.
Which means the factory has hard limits. I was actually looking at the scale of this in the sources, and it is staggering.
The numbers drop so fast.
Yeah, like a normal platelet count is roughly, 150,000 to 450,000 per microliter of blood.
Yep. That's a healthy baseline.
But when that tissue factor initiates the systemic clotting, those raw materials are consumed exponentially faster than the bone marrow or the liver can synthesize replacements.
Exactly. So in a DIC patient, that robust, healthy platelet count can just crash down into the tens of thousands in a matter of hours.
Hours, that's terrifying.
And the fibrinogen, which remember acts as the structural mortar for any blood clot, that gets drained down to practically undetectable levels.
The factory's warehouse is entirely depleted.
Completely empty.
And that perfectly explains the needle stick paradox from the beginning.
Right.
The patient is bleeding from a tiny puncture wound simply because there is not a single platelet or strand of fibrinogen left in circulation to patch the hole.
You've got it. That is the depleted clotting factory side of the equation. Clinically, we refer to that as severe thrombocytopenia and hypofibrinogenemia.
Try saying that 3 times fast.
I know, right? But here's the thing. The biological chaos actually goes one layer deeper.
Wait, it gets worse.
Oh, yeah. So at the exact same time the supply chain is running dry, the body recognizes that there are millions of abnormal microclots suffocating its organs.
Okay.
The system realizes it's choking. So it deploys this natural demolition crew. It releases an enzyme called plasmin.
And plasmin's job is to break down clots, right?
Exactly. Its primary job is to break down blood clots and restore blood flow.
Okay, well, I would think the body deploying plasmin to clear the highways is like the one thing going right in this scenario. I mean, it sounds like a built-in rescue mechanism.
Well, in theory, it is a rescue mechanism. But in the reality of DIC, the plasmin becomes hyperactivated by the sheer volume of clots.
Oh, so it overreacts.
Totally. It goes into this massive biochemical frenzy. And as this overactive demolition crew breaks down the microclots, it paradoxically makes the systemic bleeding exponentially worse.
Because it's destroying what little is left.
Exactly. It aggressively degrades whatever trace amounts of fibrin and fibrinogen might actually be left in the bloodstream.
So it's actively working against you at that point.
Pretty much. And this massive demolition project leaves behind high levels of protein debris just floating in the blood, which modern doctors can actually measure as D-dimer.
D-dimer, right. I saw that in the sources.
Yeah, the D-dimer level is quite literally a measurement of the wreckage. So you have an overactive demolition crew destroying the very structures the body desperately needs to stop the external bleeding.
Okay, understanding that dual mechanism like the hyperactive clotting depleting the supplies while the hyperactive plasmin destroys the remaining infrastructure, that makes the paradox make sense.
It's a vicious cycle.
It really is. But if this biological glitch is so chaotic, I'm trying to imagine how doctors in the 1950s even realized they were looking at a single disease.
Oh, it was a mess.
I mean, without modern D-dimer tests to measure the cellular wreckage, an obstetrician and a trauma surgeon must have felt like they were describing different parts of the same medical elephant while completely blindfolded.
That's a great way to put it.
How did they possibly connect the dots?
Well, the clinical confusion in the mid-20th century was just immense. I mean, imagine being a surgeon in the 1950s. You perform a perfectly clean, routine operation on a patient with zero history of bleeding disorders.
Okay.
And suddenly, out of nowhere, the patient begins hemorrhaging catastrophically from the surgical site, from their gums, from minor 5E punctures.
That must have been terrifying.
It defied every known surgical principle. But the conceptual lineage of understanding this actually started decades earlier, back in the late 1800s, with obstetricians.
Oh, really?
Yeah, they were documenting cases of massive, uncontrollable postpartum hemorrhage following placental abruption, which is, when the placenta detaches from the uterine wall too early.
Right, right.
They knew something was entirely destroying the blood's ability to coagulate, but they lacked the cellular framework to explain why.
So they were just watching the catastrophic end result without actually knowing the mechanism.
Exactly.
So who finally pulled the blindfold off?
The terminology started shifting in the 1950s. There were German researchers, notably this guy Rudolf Marx, who coined the phrase consumption coagulopathy.
Which perfectly describes it.
Yeah, I think in German it was Verbrauchskoagulopathy. Marx basically hypothesized that massive internal clotting was literally exhausting the factors needed to form future clots.
So he was on the right track.
Very much so. But the unifying framework really came from an American hematologist and pathologist named Oskar Ratnoff, who was working at Case Western Reserve in the 50s and 60s.
Okay, what did Ratnoff do?
Ratnoff studied the coagulation cascade with just intense precision. He looked at the obstetricians describing defibrillation syndrome, where mothers seemingly lost all their fibrinogen, and then he looked at the trauma surgeons describing these mysterious surgical bleeds.
And he realized they were the same thing.
Yes. Ratnoff helped prove that these patients weren't just failing to produce clotting factors, they were over-consuming them. That simultaneous activation and consumption model was the scientific bridge that finally tied the clot and the bleed together into one syndrome.
Well, here's where it gets really interesting, because we see Ratnoff piecing this together in a somewhat modern clinical setting, but the sources highlight this incredible story from the 1860s that hints at the underlying triggers.
Oh, the Trousseau story.
Yes. A French physician named Armand Trousseau documented this phenomenon where cancer patients developed migratory thrombophlebitis,
Right.
which, for you listening, these were aggressive blood clots that would appear in one vein, resolve, and then spontaneously appear in a completely different vein.
Just migrating around the body.
Exactly. And Trousseau theorized that the malignancy itself was somehow altering the blood's chemistry to favor clotting.
And, Trousseau's observation remains a total cornerstone of medical education today because of the tragic irony attached to it.
Yeah, this part is wild.
Years after publishing his findings on how cancer triggers these systemic migratory clots, Trousseau actually diagnosed his own fatal gastric cancer.
He noticed it in himself.
Exactly. He realized he had it because he noticed those exact same migratory clots forming in his own body.
Which is just incredibly poignant. And honestly, it highlights a fundamental rule of DIC that we really need to emphasize for you all today.
Which is?
DIC is never the primary villain. Like, it doesn't just happen spontaneously on a random Tuesday.
Right, right.
It is always a secondary reaction. It's like a weapon picked up by another disease. Malignancy, as Trousseau experienced, is one of the big three triggers highlighted in the text, alongside sepsis and obstetric emergencies.
Yep, the big three.
So let's look at how sepsis manages to flip this master switch, given that the sources say it's the most common trigger in the intensive care unit.
Sure. So when a patient develops gram-negative bacterial sepsis, the bacteria are multiplying in the blood, right? And they release this endotoxin called lipopolysaccharide. Yes, it is. This endotoxin acts as a massive inflammatory bomb. It literally forces the body's immune cells and the endothelial cells lining the blood vessels to suddenly express tissue factor on their surfaces.
And remember, tissue factor is supposed to be hidden.
Exactly.
Yeah.
But sepsis forces it out into the open vascular space. So the crosstalk between the severe inflammation and the coagulation system essentially short-circuits the blood into clotting everywhere.
And the stats on this are crazy. Studies show that DIC develops in roughly 30 to 50% of all patients with severe sepsis.
Yeah, it's incredibly common in those severe ICU cases.
A 30 to 50% incidence rate is staggering. So the bacteria literally force the blood vessels to expose the alarm bell.
Basically.
But if sepsis relies on this inflammatory storm building over a period of days, the second major trigger obstetric emergencies seems to operate on a terrifyingly compressed timeline.
Oh, absolutely.
The sources highlight amniotic fluid embolisms and placental abruptions.
And the speed of onset in obstetrics is why these remain classic, highly feared medical teaching cases.
Why is it so fast?
We really have to look at the evolutionary biology here. The uterus during childbirth requires massive, highly localized clotting power to prevent the mother from bleeding out after delivery.
Okay, that makes sense.
Because of this, amniotic fluid and placental tissue are exceptionally rich in tissue factor. It's a natural evolutionary defense mechanism.
Right.
But if a placental abruption occurs, or if amniotic fluid accidentally breaches the maternal bloodstream during a really difficult labor, an overwhelming dose of tissue factor enters the systemic circulation all at once.
Oh. So the defense mechanism gets unleashed in the completely wrong compartment.
Exactly.
Reading the clinical timeline in the text literally stopped me in my tracks.
It's jarring.
I mean, a patient could go from a totally normal, joyous delivery to experiencing uncontrollable, life-threatening hemorrhaging from her 5E sites in under an hour.
Yeah.
The speed at which the body's entire reserve of clotting factors can just be drained dry by that sudden influx of tissue factor, it leaves the medical team with almost zero margin for error.
The cascade starts in minutes. It's really terrifying.
And then there's the third major trigger, malignancy, which operates on a similarly explosive mechanism in certain cancers, right?
Yes. I mean, Trousseau dealt with a slower chronic form of DIC in gastric cancer, but modern hematology deals with acute promyelocytic leukemia, or APL.
Right.
In APL, the bone marrow overproduces these abnormal white blood cells called promyelocytes. And these leukemic cells are just packed with microscopic granules containing highly potent procoagulant material.
Like little clotting bombs.
Exactly. So when the cells inevitably break open, they dump all those granules directly into the blood plasma, fundamentally altering its chemistry and triggering severe DIC.
The sources mention that this specific leukemia is such a hematologic emergency that oncologists will start a specialized therapy called ATRA the literal moment they suspect it.
They don't even wait.
Right. They don't wait for the genetic test to confirm the diagnosis because if they delay, the DIC might cause a fatal brain hemorrhage before the cancer itself can even be treated.
Exactly. The malignancy initiates the glitch, but the glitch becomes the immediate threat to life, which brings us to the profound dilemma facing any critical care team trying to manage this.
Yeah, I have to stop here and challenge the treatment logic for a second.
Go for it.
Because I'm trying to put myself in the shoes of an ER doc. If a patient is actively bleeding out in front of me, transfusing platelets and clotting factors seems like the most intuitive, obvious intervention possible.
Right, it's reflex.
But if we know the underlying physiological problem is that the patient's body is actively using those materials to build millions of microscopic clots that are shutting down their organs, aren't we just tossing more wood into a burning fireplace?
That is the exact debate.
Aren't we just giving the glitch more raw materials to create more roadblocks?
It is the ultimate catch-22 of critical care. The feeding the fire dilemma is not just a theoretical risk. It's a profound physiological reality.
So what do you do?
Well, you are putting fresh platelets into a system designed in that moment to turn them into organ-destroying microthrombi. However, the medical consensus has landed on a grim, practical reality.
Which is?
If a patient is actively hemorrhaging and their factor levels are severely depleted, replacement therapy giving platelets, cryoprecipitate, and fresh frozen plasma remains the standard supportive care.
You just have to do it.
You have to prevent the patient from bleeding to death in the short term. It buys you the hours needed to treat the underlying sepsis, or deliver the baby, or administer the leukemia drugs.
But wait, if the root cause is systemic clotting, why don't doctors just reach for the off switch?
What do you mean?
Like, why not introduce a powerful blood thinner like heparin to shut down the factory glitch and stop the microclots from forming in the first place?
Right. I mean, administering a powerful blood thinner to a patient who is literally actively bleeding from their gums or their surgical wounds, that goes against basically every deeply ingrained clinical instinct.
Yeah, I guess that would be terrifying.
It is genuinely terrifying to execute. Outside of some very specific protocols in Japan, there's been immense global hesitation to use anticoagulants for DIC. Precisely because the risk of exacerbating the catastrophic hemorrhage is so incredibly high.
Which makes total sense. But the desire for, like, an elegant off-switch led to one of the biggest clinical trials mentioned in the text.
Oh, Zegras.
Yes. The sources detailed the rise and fall of a drug called Zegras. This was recombinant activated protein C.
Right.
The theory was that since DIC consumes the body's natural anticoagulants, simply replacing them with a synthetic version would calm the storm.
And Zegras is the quintessential cautionary tale of critical care medicine.
How so?
Well, in 2001, it actually received FDA approval based on the PROWESS trial, which showed a mortality benefit in patients with severe sepsis.
So it worked.
Well, the mechanism seemed brilliant on paper. It targeted the coagulopathy directly, replacing the activated protein C that the systemic inflammation had depleted. It was supposed to downregulate the excessive thrombin generation.
Okay, so it fixed the lab numbers. It made the blood look better on a spreadsheet.
It did. But human physiology is vastly more complex than a single biochemical pathway.
Right.
A decade later, in 2011, a massive, rigorous follow-up trial called PROWESS Shock was completed. And it failed entirely to show any survival benefit for the patients.
Wow.
Any at all.
None. The drug was pulled from the global market. It was a really harsh, necessary lesson for the medical community.
Which is what?
The redundancy and complexity of biological systems mean you can't simply block one pathway of a systemic inflammatory storm and expect it to cure the patient. Treating a patient's DIC score on paper just did not translate to saving their life.
Which is wild, and given how paradoxical this entire syndrome is, I have to imagine it's incredibly easy to misunderstand, even for medical professionals.
Oh, absolutely.
Because when I first started reading the sources, my immediate instinct was to categorize DIC as just a massive, complex bleeding disorder. But that is fundamentally wrong.
It's probably the most dangerous misconception you can have about the condition.
DIC is, first and foremost, a clotting disorder. The hemorrhage is merely the secondary consequence. It's just the alarm bell ringing because the supplies are gone.
Because the factory is empty.
Exactly.
Yeah.
The medical community has to constantly remind itself that organ failure from widespread microscopic thrombosis is what silently kills many of these patients, long before the visible bleeding becomes the primary issue.
Another thing I noticed in medical headlines is the phrasing that a patient caught DIC or developed it out of nowhere.
Yeah, that phrasing is terrible.
We established earlier that it requires a trigger, but I want to reiterate for everyone listening. Treating the DIC without addressing the root cause is entirely futile, right?
Completely futile. Treating DIC in a vacuum is like Bailing water out of a sinking ship without patching the hole in the hull.
Great analogy.
If you don't administer antibiotics for the sepsis, or deliver the placenta, or give the targeted chemotherapy for the leukemia, the tissue factor will just keep ringing the alarm bell, and the consumption will continue until the patient dies. Furthermore, people often assume DIC is some exotic, rare disease featured on television medical dramas. But as we noted with the sepsis statistics, it's an everyday reality in intensive care units worldwide.
And if we pull back and look at the bigger picture, understanding this paradox has completely reshaped how modern medicine approaches emergency care.
Oh, totally.
Like, think about how emergency departments handle massive transfusion protocols today. Historically, a severe trauma patient would just be pumped full of bags of packed red blood cells to replace the lost volume, right?
Just give them blood.
But because researchers now understand trauma-induced coagulopathy, which shares critical physiological pathways with DIC protocols, have entirely changed.
They're much more precise now.
ERs now maintain strict fixed ratios. They give 1 unit of red blood cells, 1 unit of plasma, and 1 unit of platelets. They are proactively flooding the system with clotting factors from minute 1.
Because they're anticipating the glitch. They know the massive tissue trauma is going to expose tissue factor, and they are ensuring the factory warehouse doesn't run dry before the surgeons can even repair the physical damage.
It's just a remarkable scientific journey from the late 1800s to today.
It really is.
So, to summarize what we've unpacked today, disseminated intravascular coagulation is a tragic, systemic overreaction. It is a biological glitch that commands the body to clot everywhere all at once, consuming the entire reserve of natural clotting factors, leaving a patient suffering from lethal thrombosis and catastrophic hemorrhage simultaneously.
Yep, that's it in a nutshell.
It really forces us to respect the sheer complexity of the human circulatory system.
And, that complexity is actively driving a whole new debate today.
Oh.
Yeah, the source text actually notes that leading researchers are currently arguing that DIC should no longer even exist as a single catch-all diagnosis.
Wait, really? After all this?
Yep. The pathophysiology is so distinct depending on the trigger that they're proposing, we split it into 2 distinct subtypes.
Okay, what are they?
A bleeding phenotype, which is heavily associated with obstetrics and leukemia, and an organ failure phenotype associated with sepsis, because treating a sepsis patient exactly the same as an obstetric patient could actually be causing harm.
So the very term DIC might eventually become a historical relic.
It is highly possible. Just as the 1950s term consumption coagulopathy was eventually replaced by our modern understanding of DIC, we might literally be looking at the end of DIC as a singular disease entity.
That is fascinating.
It's the ultimate proof that in medicine, the closer we look at the microscopic mechanics, the more we realize how deeply nuanced the human body truly is, and how much we still have to learn.
I love that. It's a perfect reminder that scientific understanding is never truly settled. It is always evolving.
Always.
Think back to that patient we started with, caught in the impossible space between the microclots shutting down their organs and the needle stick that won't stop bleeding. It's not just a medical paradox. It is a window into the incredibly fragile, intricate balance that keeps us alive every single second of the day.
Very true.
Thank you for joining us on this deep dive into the source material today. And as always, keep questioning the world around you.